This information presented in this course is based on reference materials that are believed reliable and consistent with standards accepted at the time of presentation. Possibility of human error and ongoing research and development in medical sciences does not allow assurance that the information contained herein is in every respect accurate or complete. The information presented during the course is intended for teaching of undergraduate and graduate students in biomedical education and is intended only for teaching. Students who successfully complete this course should check the product information sheet included in the package of any drug they plan to administer or dispense to be certain that the information presented in this course is accurate and that changes have not been made in the recommended dose or in the contraindications for administration. July 9th, 2014. Anti-anginals, or drugs to treat angina. These include the nitrates, the beta blockers, the calcium channel blockers, and ranolazine. The regulation of smooth muscle contraction and relaxation is shown here in this figure. As we can see, drugs may relax vascular smooth muscle in several ways. One way is by increasing cyclic GMP, as you can see here on the bottom right. Doing so facilitates the dephosphorylation of myosin light chains and prevents the interaction of myosin with actin. Nitric oxide, for example, is an effective activator of soluble guanylyl cyclase and acts mainly through this mechanism. Important molecular donors of nitric oxide include nitroprusside and the organic nitrates used in angina. Decrease intracellular calcium, the calcium channel blockers. These predictably cause vasodilation because they reduce intracellular calcium, which is a major modulator of the activation of myosin light chain kinase. Beta blockers and calcium channel blockers also reduce calcium influx in cardiac muscle fibers and thereby reduce the rate, contractility, and oxygen requirements of the heart under most circumstances. Well, another way to regulate smooth muscle contraction in the blood vessel is to stabilize or prevent depolarization of the vascular smooth muscle cell membrane. Recall that the membrane potential of excitable cells is stabilized near the resting potential by increasing potassium permeability. Potassium channel openers such as minoxidil, for example, increase the permeability of potassium channels, probably ATP-dependent potassium channels. Certain newer agents under investigation for use in angina may in part act by such a mechanism. Lastly, increasing cyclic AMP in vascular smooth muscle cells. As we see here in the figure, an increase in cyclic AMP increases the rate of inactivation of myosin light chain kinase, the enzyme that's responsible for triggering the interaction of actin with myosin in these cells. This appears to be the mechanism of vasodilation caused by beta-2 agonists, drugs that are not used in angina. And the reason why is that they may cause too much cardiac stimulation. Neither here nor there, this diagram clearly illustrates a few of the mechanisms involved in contraction and relaxation. On the one hand, on the left, we see calcium pathway stimulating the calcium calmodulin complex in the myosin light chain kinase to make a phosphorylated myosin, which then went on phosphorylated myosin light chain kinase, which then went on to interact with the myosin light chains to phosphorylate them, allowing them to interact with actin and contract the cell. Okay, so when you look at this slide, be careful to understand what's going on. What is calcium normally doing? What does blocking calcium result in? What is cyclic GMP normally doing? What is ATP normally doing? So here we have a more complex drawing where we include the endothelium, the interstitium, and the vascular smooth muscle cell. And this slide very importantly illustrates the mechanism of action of nitrates, nitrites, and other substances that increase the concentration of nitric oxide in vascular smooth muscle cells. The steps leading to relaxation are shown here in the green arrows. And as you can see, nitric oxide will come into the cell from the endothelium, will come into the vascular smooth muscle cell from the endothelium through diffusion, and will stimulate guanylyl cyclase, and guanylyl cyclase will stimulate cyclic GMP. In the meantime, the nitrates and the nitrites are similar to nitric oxide, and sildenafil is in some ways similar, but in other ways different, because it acts as an inhibitor of phosphodiesterase. By inhibiting phosphodiesterase, cyclic GMP levels stay high. And so the mechanism of action of nitrates, nitrites, and other substances that increase the concentration of nitric oxide in vascular smooth muscle cells is shown here. Nitrates, as we just saw, help to relax smooth muscle, and in this way control angina due to their smooth muscle relaxant activity. They work by promoting venous and to a lesser extent arterial dilation. The major anti-anginal effect of nitrates is to decrease myocardial oxygen demand. The venodilation causes peripheral pooling of the blood, which results in reduced ventricular filling, also known as a reduced preload. Because of this, systolic wall tension and thus that ventricular work are reduced. Systemic arterial vasodilation due to nitrates reduces pressure against which the heart pumps, a reduced afterload. And this also reduces cardiac work. So venodilation causes peripheral pooling of the blood, which results in reduced ventricular filling, reduced preload. Systemic arterial vasodilation due to nitrates reduces pressure against which the heart pumps, reduced afterload. A secondary anti-anginal function of nitrates may be improved myocardial perfusion, which may occur via dilation of epicardial arteries at the site of asymmetric stenoses. Nitrates may also block coronary artery spasms, or post-stenotic regional perfusion may be improved due to dilation of collaterals. Of all anti-anginal medications, only sublingual and chewable forms act fast enough to treat acunic anginal attacks. The symptoms are usually relieved within 5 minutes, and fast-acting nitrates may also be used just prior to symptom-provoking situations. The various long-acting nitrates are used prophylactically. Choice of a long-acting nitrate depends on duration of action, patient acceptance, cost, etc. Nitrates are drugs of first choice in stable, unstable, and variant angina. And for maximum anti-anginal coverage, titration to rather high doses may be necessary, provided this is well tolerated. Now, the most common side effects of the nitrates are headaches. Others include hypotension, dizziness, and palpitations. Side effects may lessen with time and may even be avoided if dosage titration is gradual. Nitrates have no contraindications but require caution with hypotension, postural hypotension, and acute myocardial infarction. pharmacologic management of angina, nitrates, and their therapeutic actions. When you look at the graph below, what you see is a plot of the myocardial oxygen demand versus various types of instances that may increase that demand. And so in a hypothetical drawing, as you look here from the left to the right, the solid black line would represent the myocardial oxygen demand for that particular patient. And there comes a point where there's a peak that this patient's body is not able to meet. So if we look at that big block arrow pointing down in the hatched region, you see that there comes a moment where that patient needs more oxygen than his or her body can supply. Perhaps this is exercise, perhaps this is some kind of stress. But the patient's body can only supply what the dashed line shows. And so for most of the time, it's sufficient. But there are these episodes of angina. And so nitrates are very good vasodilators. And they reduce the preload, they reduce the afterload by dilating both veins and arteries. And so basically what happens is that as we reduce these loads on the heart, we reduce the oxygen demand. And so we bring that peak down to the plateau region that the body is able to deal with and supply. And so here, in response to the nitrates, you have less work on the heart, less preload, less afterload, and now you can get dilation of the blood vessel, or you could have the spasm block, but ultimately you'll have increased blood flow, which will bring oxygen to the heart. And so these vasodilators are powerful in that regard. Now, I'll pause for a moment here to introduce the concept of nitrate tolerance. And I could have probably done this in a different place, but I'd like to talk about it for a moment or two. And so what's been observed is that with continuous exposure to nitrates, smooth muscle may develop complete tolerance, which is known as tachyphylaxis. And the patient can become progressively tolerant, in particular when long-acting preparations or continuous intravenous infusions are used for more than a few hours without interruption. And so while the mechanism behind tolerance is not completely understood, and there are several good review articles on this, ranging in length from 4 pages to 40 pages, but neither here nor there, while the mechanism of tolerance is still being deciphered, basically we know that if we put a break in between dosing, this is one way to circumvent it. And one important aspect of this is that tolerance does not occur equally with all of the nitric oxide donors. For example, nitroprusside retains activity over very long periods. Other organic nitrates appear to be less susceptible than nitroglycerin to the development of tolerance. And so not all nitrates have the same degree of tolerance, but tolerance is something that should be examined or looked for in the patient, because obviously the drug will stop working, and that can cause increased pain again and increased stress on the heart. This is a series of panels that show the effects of vasodilators on contractions of human vein segments that were studied in vitro. In panel A, in the top left, we see contractions that are induced by 2 vasoconstrictor agents, norepinephrine and potassium. So this is just contractions that are stimulated by vasoconstrictors. The left portion of panel A shows potassium, very good at causing vasoconstriction in vitro of these isolated veins. Norepinephrine can increase the contractions a little bit more. But nonetheless, if you reverse the order in which you present the drug, if you give norepinephrine first or potassium second, you still get potent vasoconstriction. Okay, so now compare that to what's going on in panels B and C. Panel B shows the relaxation induced by nitroglycerin. Okay, so if we look, first norepinephrine is administered down in panel B in the lower portion. You're getting contraction. That contraction is persisting over time in vitro. However, upon addition of nitroglycerin, we see that the constriction is reversed and the blood vessel relaxes again. You see that red line coming back down to baseline, more or less. If you look at the upper portion of panel B, the same kind of effect generated in response to potassium. We see a vasoconstriction that can be partially reversed by nitroglycerin. And one thing that one should note is that this relaxation is rather prompt. Over the scale of minutes, as you can see, we're getting vasorelaxation. In panel C, we have the relaxation induced by a calcium channel blocker. And as you can see, following depolarization by potassium, verapamil will relax that blood vessel again, but the duration needed to do so is longer than nitroglycerin. And so this is one of the major reasons why nitroglycerin can be taken shortly after an angina attack begins, and it starts to work quickly. It's faster in terms of its response than verapamil. However, nitroglycerin has certain issues to consider, and one of them is tolerance. And so long-term treatment with certain nitric oxide donors can cause tolerance more than others, and nitroglycerin is one of those in which tolerance can form. Okay, so of course verapamil, and we'll talk about calcium channel blockers in a moment, is effective, but nitroglycerin is faster at getting that relaxation to begin. Nitroglycerin is out on the market with various trade names, some of which are listed here. As you can see, there are many formulations of the product. Because of its rapid onset of action, usually between 1 to 3 minutes, sublingual nitroglycerin is the most frequently used agent for the immediate treatment of angina. But because its duration of action is short, on the order of 20 to 30 minutes, it's not suitable for maintenance therapy. The onset of action of IV nitroglycerin is rapid, but clinical use of IV nitroglycerin is restricted to the treatment of very severe and recurrent rest angina. As you can see here, there are more slowly absorbed preps of nitroglycerin, including a buccal form, oral preps, and several transdermal forms. But these formulations, while useful at providing blood concentrations for sufficient effect for longer periods, they tend to associate more with the development of tolerance. So the mechanism of action of nitroglycerin, again, we've discussed. We see decreased venous return to the heart, resulting in the reduction of intracardiac volume, a decreased preload. Arterial pressure also decreases, so there's a decreased afterload. And so vasodilation action, both on veins and arteries, is a major mechanism contributing here, which leads to decreased myocardial work, decreased need for oxygen. We also see dilation of non-diseased blood vessels, both the non-diseased coronary arteries, non-diseased peripheral vessels. And so these vasodilators are very potent and may cause hypotensive responses or reflex responses. So, for example, as the blood vessels dilate and the peripheral vascular resistance drops, the body may compensate by having the heart beat faster, right? A tachycardia response, which obviously is going to increase the work of the heart as well. So, complex mechanism, but predominantly focused on increasing perfusion to the blocked or occluded blood vessels. So the kinetics of nitroglycerin, again, depending on the formulation, sublingual has the fastest onset, between 1 and 3 minutes. Oral will take 15 to 30 minutes. There are other oral types of formulations which will take longer for onset. There's a spray, there's transdermal formulations, but generally speaking, the most common will be sublingual or oral. There's wide distribution throughout the body, about 60% protein bound, and highly metabolized in the liver. Okay, so the liver will convert this to active metabolites as well as inactive metabolites. But neither here nor there, in terms of treating an acute episode of angina, drugs given sublingually, because it bypasses the liver. Sublingual administration puts it directly into the bloodstream. Particularly, the drug drains down into the superior vena cava and gets right to the heart very quickly. So adverse effects of nitroglycerin include throbbing, headache, dizziness, or weakness, which may be associated, of course, with orthostatic hypotension, flushing, heart palpitations as a reflex tachycardia may affect the patient, sublingual burning in some patients or stinging, and depending on the type of formulation, if the drug is given, for example, as a patch, you might see a rash or contact dermatitis. Some people may show a vasodilatation allergic reaction, but very unlikely. Nitroglycerin and drug interactions. If combined with antihypertensives, nitroglycerin may cause a strong hypotensive response. It already does that based on its vasodilation action, and so in combination with antihypertensives, needs to be monitored. When given with ergot alkaloids, we see in some patients a precipitation of angina, and so that combination may need to be avoided. When given with sildenafil, which is a phosphodiesterase inhibitor, also known as Viagra, we see the potentiation of hypotension. And when administered with ethanol, can cause hypotensive action as well. So some miscellaneous considerations. Nitroglycerin, use sublingually for an acute attack and for prophylaxis. If it's going to be administered via ointment or patch, apply to the trunk of the body. Use NSAIDs for initial headache. Use sublingual to minimize tolerance. And rotate the patch, store, and replace sublingual tablets as they age and get expired. This table from your book depicts the most common formulations of nitroglycerin, their dose and their duration. I'm not going to ask here for doses, although you should know that these doses tend to be milligram doses, not microgram and not gram doses. But we can look at them based on their duration of action. Are they short-acting or are they long-acting? And so if we look, for example, at nitroglycerin sublingual, its duration of action is short, between 10 and 30 minutes. Or isosorbide dinitrate, between 10 and 60 minutes, also sublingually. Amyl nitrite is one of the first nitrates, or I should say nitrites, that was studied medically, but it's highly volatile. And so it's highly volatile. It's dispensed in a glass ampule. It has a strong, unpleasant smell associated with it. And so it's unlikely these days that your patients will be on that particular nitrite. Much more likely to see nitroglycerin or isosorbide dinitrate. Now, on the longer-acting nitrates, you have nitroglycerin as an oral sustained acting, or as a transdermal, or as a buccal. So transdermal, I should say, as an ointment or as a patch. There's different formulations. And then there are different formulations of isosorbide dinitrate and isosorbide mononitrate. Okay, so basically here on the long-acting, we're either dealing with nitroglycerin or isosorbide dinitrate or mononitrate. This table from our book lists some of the beneficial effects and some of the deleterious effects of nitrates in the treatment of angina. So, in terms of potential benefit, decrease ventricular volume, decrease arterial pressure, decrease ejection time, vasodilation of the epicardial coronary arteries, which are often to blame here, increase blood flow, and decrease left ventricular diastolic pressure. Okay, so as we look at these effects, we see that the results are basically either decreasing oxygen requirement of the myocardium, relief of spasm, or improving perfusion of blood flow through the coronary arteries. For potential deleterious effects, as I mentioned, the reflexes may kick in, such as reflex tachycardia or reflex inotropic response, and that will cause an increase in the requirement for oxygen, and it's something we'd like to minimize. Make sure that the doses we use are not doing this regularly. Another potential deleterious effect is decreased diastolic perfusion time because of the tachycardia and decreased coronary perfusion. Okay, so these are more likely to occur with the systemically absorbed drugs than with the sublingual, because of the fact that as you get systemic vasodilation out there in areas that are not directly related to the coronary blood vessels, coronary arteries, now you might kick in these responses. So it's just important to keep an eye on this. I mean, is the drug working? Does the patient feel relief? Obviously, if they're kicking in reflexes, they're not going to feel that good. They're not going to feel that the drug's working that well. So you may just need to ask them. So I guess before moving on to the next slide, one of the take-home messages here is location. Where have you inserted the drug? Where have you administered it? Is it going all throughout the body and having lots of systemic effects, or have you kind of just put it in the buccal area or under the tongue, where it's mostly being absorbed right into the heart, where it's having its greatest effect in terms of its medical use? Okay. This table lists some of the nitrate-drug interactions that are well known. Of course, some of these have been mentioned. For example, alcohol administered with nitrates may produce a severe hypotension, and cardiovascular collapse may occur. The heart may be unable to pump, particularly in excessive amounts of alcohol and nitrates. Aspirin, when given with nitrates, so increased nitrate serum concentrations and actions may occur. Again, some people may be taking that aspirin to prevent headache, but we may see increased duration of action in the blood and increased likelihood of things like tolerance. When given in combination with calcium channel blockers, nitrates may cause an increased orthostatic hypotension. So dosage adjustment of either drug may be required. Or with an ergot alkaloid like dihydroergotamine, you can see an increased bioavailability of the ergot and a resultant increase in mean standing systolic blood pressure. Or you may see functional antagonism between the agents and therefore a decreased effect, a decrease in the anti-angina effect of the nitrate. Fourthly, when nitroglycerin and heparin are combined in a patient, you may see decreased pharmacologic effects of heparin, and so there may need to be dosage adjustment. But again, in that instance, it depends if the nitrate is long-acting, if it's going to be chronically administered. An occasional sublingual application may not be a dramatic effect on heparin, while someone on sustained or longer-acting nitroglycerins, this may need to be examined. Okay, so these are some of the relevant nitrate drug interactions: alcohol, aspirin, calcium channel blockers, ergot alkaloids, and heparin. Isosorbide dinitrate is known by several different brand names. It's available as sublingual administration or sustained acting chewable tablets. The mechanism of action is the same as nitroglycerin. It's said to have longer sublingual coverage than nitroglycerin, slightly longer, as we saw in one of the tables previously. It's metabolized to active metabolites, including the mononitrate, and the mononitrate is longer acting than the dinitrate. And so, except for the sublingual dosage form, it's rarely used today because of high tolerance liability. It's been replaced by the mononitrate, which has less tolerance associated with it. Isosorbide mononitrate. It's also known by its brand names of Imdor or ISMO. And this is a primary long-acting nitrate. Okay, this one's got a duration of action about 6 to 12 hours. Its mechanism of action is the same as nitroglycerin. In terms of kinetics, its peak action is anywhere from 30 to 60 minutes. But its duration of action is anywhere from 6 to 10 hours. It's completely bioavailable, not very highly protein bound. It bypasses first-pass metabolism and therefore has a low tolerance liability. It's a metabolite of the dinitrate. About 1% of it is eliminated in urine, and its duration of action has been extended out to about 24 hours with an extended release formulation. Okay, so this one's an interesting drug. It's a long-acting metabolite of isosorbide dinitrate, and it's effective, and it's used often for kind of chronic management of angina. There is tolerance that's been associated with it, but there have been ways established to circumvent that, generally by either spacing the time you take the drug by more than 7 hours, or by taking this once-a-day long-acting form and some clinical data to support its efficacy. So anyway, this is another drug available. It's a metabolite of the isosorbide dinitrate, and it's the longest acting of the bunch. Isosorbide mononitrate side effects. Similar to nitroglycerin, we see cardiovascular effects like flushing or orthostatic intolerance, or in some cases palpitations and tachycardia due to reflexes. Ankle edema or fainting have been reported. GI effects like nausea or vomiting have been reported. Musculoskeletal effects like joint pain, some respiratory effects, a low incidence, things like bronchitis or upper respiratory infection or pneumonia. Cutaneous vasodilation or rash, hypersensitivity reactions, or sublingual burning. Again, these are some of these are more common than others, like sublingual burning in the oral forms. Again, this is usually taken orally and not necessarily sublingually, but anyway, these incidences are relatively low. But things like flushing or orthostasis or tachycardia are worthy of note in patients taking this drug. In terms of drug interactions, similar to those we've talked about with nitroglycerin, things like ethanol, for example, things like the ergot alkaloids, for example. This slide summarizes our discussion now on the nitrates. And we'll focus on nitroglycerin here, but realize that isosorbide dinitrate and isosorbide mononitrate, in terms of mechanism and many of the adverse effects, will be similar, and where they will differ will be in terms of duration of action, for the most part. And so back to nitroglycerin, mechanism of action: it releases nitric oxide in smooth muscle, it activates guanylyl cyclase, increases cyclic GMP levels. And the effect of that is smooth muscle relaxation, especially in blood vessels. Other smooth muscle is relaxed, but not as markedly. The vasodilation decreases venous return and heart size, may increase coronary flow in some areas, and in variant angina. In terms of clinical application, the sublingual form for acute episodes of angina, there are oral and transdermal forms for prophylaxis, and an IV form for acute coronary syndrome, particularly in hospital setting. Pharmacokinetics, toxicities, and interactions. So very high first pass effect. So sublingual dose is much smaller than oral dose is, because sublingual circumvents the gut. High lipid solubility ensures rapid absorption. But in terms of toxicities, the predominant and most common ones include orthostatic hypotension, tachycardia, or headache. And in terms of drug interactions, we've mentioned a few: alcohol, calcium channel blockers, may require dose adjustments and such. Also, synergistic hypotension has been observed with the phosphodiesterase type 5 inhibitors like sildenafil. In terms of isosorbide dinitrate, very similar to nitroglycerin with a slightly longer duration of action. And isosorbide mononitrate is the active metabolite of the dinitrate. It's used orally for prophylaxis and is the longest acting of the bunch. Beta blockers. Beta blockers help control angina by competitively blocking catecholamine uptake by myocardial beta receptors. This results in blockade of sympathetic stimulation, and the heart rate and contractility are therefore decreased. During exertion or stress, which increases in the heart rate, contractility, and systolic blood pressure, are now going to be somewhat blunted due to the beta blocker, and the oxygen demand on the myocardia is going to be lowered. Beta blockers are drugs of first choice in stable and unstable angina, and are commonly given along with nitrates. However, they are not usually used in variant angina since they have no antispasmodic effects. Beta blockers are generally safe and well tolerated. Reported side effects include rare heart failure in those with severe left ventricular dysfunction, bronchospasms in susceptible patients, peripheral ischemia, fatigue, CNS effects, and bradycardia. Beta blockers possessing certain pharmacologic properties may be less likely to cause some of these side effects. For example, beta-1 selective blockers are probably going to circumvent bronchospasms, for example. Beta blockers may reduce myocardial infarction and death rates based on secondary prevention trials after acute myocardial infarction. However, cardioprotective effect in angina patients with no myocardial infarction history are not proven, and that bradycardia is the aim of beta block. That's what you're doing. You're slowing down the rate of contraction. You're slowing down the strength of contraction, which is alleviating some of the oxygen demand on the myocardium. And that looks like this. If we look at beta blockers, the solid black line would be the myocardial demand. The dashed black line would be the myocardial supply. And one way to bring that peak down, because you can't really bring the plateau up, right? And so the method here is to reduce demand. Well, beta blockers will reduce the heart rate, the strength of contractility, reduce the systolic blood pressure during exercise. And so the beta blocker reduces the oxygen demand on the myocardium and is therefore efficacious for treatment of angina. The anti-anginal effects of all available beta blockers appear equal, but the beta blockers are many, and they differ in terms of some pharmacodynamic and pharmacokinetic properties. We have those which are beta selective, beta-1 receptor selective, and we have those which are non-selective, and we'll discuss them as we go on. Now, there are two subtypes of beta receptors, and this is a review at this point, the beta-1s and the beta-2s. The distribution in the body and the effects of stimulation of the two subtypes are shown on the next slide. The anti-anginal action of beta block is due to the effect on cardiac beta-1 receptors, while beta-2 block may cause side effects, especially bronchospasms in people who are susceptible, let's say asthmatic patient or patient with COPD. But there are newer beta blockers like atenolol or metoprolol, which we call cardioselective because they preferentially block the beta-1 receptor. And it appears that the cardioselective agents are generally safer and better tolerated in those with obstructive pulmonary disorders or peripheral vascular disease or insulin-induced hypoglycemia. Now, they still require some caution. Those types of patients should be monitored, but the beta-1 selective drugs appear to be the better option in such patients. No beta blocker is indicated in asthma patients unless the need for beta block is overriding. And in such cases, then a cardioselective beta-1 receptor blocker at low dose is probably the best approach to begin with. The distribution and function of beta receptor subtypes. So this is hopefully by now just a review, but let's look again closely at where we have beta receptors predominantly and where we have beta-1 receptors predominantly and beta-2 receptors predominantly. First with the beta-1s. We see that these receptors predominate in the heart, where they function to stimulate the heart's rate of contraction and strength of contraction. We see beta-1 receptors predominate in the liver, where they stimulate lipolysis, also some beta-2 stimulation, but predominantly beta-1 there. And in the kidney, we see beta-1 receptors predominate, and we believe that that results in the release of renin. Now, beta-2 receptors predominate in areas such as the lung, where they function to allow bronchodilation, or peripheral blood vessels, where they function to allow vasodilation. Also in the pancreas, where they stimulate insulin release, and the skeletal muscle, where they stimulate glycogenolysis. Okay, so if these are where the receptors are normally found, and this is what their normal function is, then blocking, for example, beta-1 receptors in the heart will slow the heart down. Or blocking beta-2 receptors in the pancreas will inhibit insulin release, and so on. Recall from Intro to Pharmacology that when you were first introduced to beta blockers, a few properties of beta blockers were also mentioned at that time that confer some important pharmacological activity. The first is MSA, or membrane stabilizing activity. And again, this is an important parameter to be aware of, because this type of beta blocker would not be used, for example, in the eye because of potential eye toxicity due to the membrane stabilizing action. But membrane stabilizing activity seems to be less of an issue for example, applications in the heart. And so propranolol has the most membrane stabilizing activity, and that's why you'd never use it, for example, to treat glaucoma, but you can use it to treat, for example, hypertension or other disorders, systemic. Metoprolol and pindolol, on the other hand, have slight membrane stabilizing activity. And this is theoretically useful in improving antiarrhythmic effects of beta block. But the MSA has not always correlated with antiarrhythmic effect per se. And so we'll leave that up to further debate. It has not been found clinically, especially at usual anti-anginal doses, that MSA activity of a particular beta blocker is giving a better antiarrhythmic effect. And we'll mention the beta blockers in the chapter on cardiac arrhythmias after the midterm. So just file that away and keep that in mind. Now, another property of some beta blockers is intrinsic sympathomimetic activity, or ISA. And in fact, these compounds are not just bona fide antagonists that block the receptor, but rather these are partial agonists that have some activity at the receptor, but less activity than the endogenous ligand. And so, for example, pindolol has significant intrinsic sympathomimetic activity, while timolol has slight ISA. So, for example, compared to propranolol, what do you think will happen with pindolol for an adverse effect like tachycardia, for example? All right, pindolol, because it has partial agonist activity. Now, drugs with ISA theoretically have fewer of certain side effects, but again, this has not panned out per se in the clinic. In theory, it would seem that they'd have fewer side effects because you're not shutting off the receptor completely. But in practice, there are other problems that can occur. Now, the largely hydrophilic water-soluble drugs are atenolol and nadolol, while the other beta blockers are mainly lipophilic and very lipid-soluble. The hydrophilic agents have the longest half-lives and may be used once a day at all doses. The hydrophilic beta blockers may be associated with fewer CNS side effects, particularly sleep disturbances, and are less likely to be involved in drug interactions. This table summarizes the pharmacology of several beta blockers. On the left, you can see pharmacodynamic properties. On the right, you can see pharmacokinetic properties. Now, let's first start with pharmacodynamic properties. Plus means that there's an activity present. Plus over minus means there's a slight activity present. And 0 means no activity. So let's look, for example, at atenolol. Has cardioselectivity, doesn't have MSA, doesn't have ISA. On the other hand, pindolol has no cardioselectivity. It has some MSA and ISA activity. Now, on the other hand, nadolol is non-selective, no MSA, no ISA. And so while these are all beta blockers, they differ in terms of their selectivity for the receptor, in terms of whether they have MSA or ISA. Now, if we look over to pharmacokinetic properties, what you see is, for example, atenolol and nadolol are hydrophilic, and they have the longest elimination half-lives of 6 to 9 hours for atenolol and 20 to 24 hours for nadolol. So this is some of the comparative pharmacology of the beta blockers, with the stress on those which are beta-1 selective or those which are partial agonists. And so this table, taken right from your book, Chapter 10, has a lot of the beta blockers that are currently used. I'm not asking you to memorize this table, but you should look down at it and see some drugs have very high ISA activity, like, for example, cardiolol, or, for example, pindolol. Excuse me. We can look down the other columns and see what's the half-life, what's the protein binding, which of them undergo first pass metabolism, and so on and so forth. Okay, so on this one, pindolol is found to have some ISA activity, moderate lipid solubility, half-life of 3 to 4 hours, protein binding about 57%, and mostly metabolized in the liver for pindolol. Alright, so I wouldn't ask you to memorize a table like this, but what are some of the common beta blockers used for cardiovascular disorders? Things like labetalol, metoprolol, nadolol, propranolol, pindolol. And so when you start to study a table like this, I'd like you to think about them in terms of which of them have long half-lives compared to the others, and which of them would you consider to be beta-1 selective, and which of these have ISA to consider. This is a summary slide of the use of propranolol, the beta blocker, in the treatment of angina pectoris. Recall that this particular beta blocker is a non-selective competitive antagonist at beta receptors. That it has its effect is that of a decreased heart rate, decreased cardiac output and blood pressure, and a decreased myocardial oxygen demand. What we see is prophylaxis of angina for this drug, for other applications. Okay, there'll be other cardiovascular applications of this drug. We're not going to go into them all now. And pharmacokinetics, toxicities, and interactions. Well, the drug is given orally or parenterally. It's got a 4 to 6 hour duration of action. Its toxicity include that using it in patients with asthma, or that have atrioventricular block or heart failure, or who have sedation that's undiagnosed. And recall that this is additive with all cardiac depressants. Atenolol, metoprolol, and the others are beta-1 selective blockers. Less risk of bronchospasm, but still significant. Here we have a schematic representation of the effect of inhibiting the voltage-activated inward displacement of calcium ions through the calcium selective channels on the functioning of the myocardium. So here we have inhibition of slow calcium current. In the myocardium, we have a negative inotropic response. In the nodal pacemaker, we have a slowed heart rate. This leads to decreased oxygen utilization. In the vasculature, we have coronary vasodilation, peripheral vasodilation, the possibility of reflex tachycardia. The vasodilation increases the oxygen supply. So we have decreased oxygen utilization as a consequence of inhibiting the channel. And we have increased oxygen supply as a consequence of coronary artery vasodilation. And so these events are efficacious in the treatment of angina. Now a little bit about that calcium channel. That voltage-gated calcium channel is the dominant type in cardiac and smooth muscle. It consists of alpha 1, alpha 2, beta, gamma, and delta subunits. Nifedipine and other dihydropyridines bind to one site on the alpha 1 subunit, whereas verapamil and diltiazem appear to bind to closely related but not identical receptors in another region of the same subunit. Binding of a drug to the verapamil or diltiazem receptors allosterically affects dihydropyridine binding. Now, blockade of calcium channels by drugs like this resembles sodium channel blockade by local anesthetics. The drug acts from the inner side of the membrane and binds more effectively to open channels than inactivated channels. Binding of the drug reduces the frequency of opening in response to depolarization. The result is a marked decrease in transmembrane calcium current, which in smooth muscle results in long-lasting relaxation, and in cardiac muscle results in reduction in contractility throughout the heart, and decreases in sinus node pacemaker rate and atrioventricular node conduction velocity. And so, the drugs that we're going to talk about here are affecting the L-type calcium channel, which is a voltage-gated channel. And it's found in the heart, in the skeletal muscle, in the smooth muscle, on neurons, for example, in endocrine cells, and in bone cells. Calcium channel blockers provide a therapeutic effect in angina by blocking calcium transport mechanisms in vascular smooth muscle and cardiac muscle fibers, and the result is a partial inhibition of contraction in these tissues. Calcium blockers are therefore effective in preventing coronary vasospasms. They also promote peripheral vasodilation and thus cause a reduction in left ventricular pre- and afterload, which results in decreased myocardial oxygen need. Some calcium blockers, like verapamil or diltiazem, directly depress heart rate and contractility. However, this action is countered by the reflex effects of peripheral vasodilation, and cardiac output may therefore remain unchanged. Calcium blockers are indicated in variant angina if nitrates alone are insufficient. They are indicated in stable and unstable angina when maximally tolerated doses of nitrates and beta blockers are inadequate, or beta blockers are contraindicated. They are also indicated in unstable angina if there is strong evidence of a significant vasospastic component. So if we look at the pharmacologic management of angina with calcium channel blockers, again we see our cartoon diagram here of the solid black line indicating the myocardial oxygen demand, and the dashed black line indicating what the patient can give. And so as you can see, the patient can only go so far in achieving the demand. And so here we have a drug that's going to reduce the peak from one which is ultra high to one which is lower and more like that of the patient with angina. The net consequence is reduced afterload, slightly reduced preload, slightly reduced contractility. And so here we have our calcium channels. The ones we're talking about today are the L-type, and they're given names from CAV 1.1 to CAV 1.3. And the V stands for voltage gated, and CA stands for calcium. So the channel name is CAV 1.1 to CAV 1.3. This slide contains the chemical structures of several calcium channel blockers. As can be seen, we have a drug here called verapamil. Verapamil was the first clinically useful member of the group and was the result of attempts to synthesize more active analogs of papaverine, which is a vasodilator alkaloid found in the opium poppy. Since then, dozens of agents of varying structure have been found to have the same fundamental pharmacologic action. Now, another calcium channel blocker shown here is nifedipine. And nifedipine is the prototype dihydropyridine. It is the most extensively studied of the group, and the properties of the other dihydropyridine can be assumed to be similar to it, unless otherwise noted. Lastly, diltiazem is another one of these miscellaneous drugs, but still very important. And we're going to talk about these drugs now as we move forward. And we'll consider drugs like verapamil and diltiazem to be different than the prototype dihydropyridine, nifedipine, here on the lower left. This table lists the clinical pharmacology of some calcium channel blocking drugs. Looking particularly at the dihydropyridines, we see that many of these drugs have varying bioavailabilities when given orally. For example, amlodipine has a very high oral bioavailability, whereas nimodipine or nisoldipine have very low oral bioavailability. The half-life of this drug class ranges anywhere from 1 to 2 hours for nimodipine to 30 to 50 hours for amlodipine. If we look at the indications of these drugs, we see things like angina and hypertension, subarachnoid hemorrhage and hypertension, all down that row. And lastly, I'm not going to hold you to doses, but you should know that doses are milligram range here. Okay, so these are dihydropyridines. We still have to talk about the exceptions, and that would be verapamil, for example, and diltiazem. The calcium channel blockers, verapamil and diltiazem, work through a non-selective block of L-type calcium channels in blood vessels and the heart, leading to reduced vascular resistance, reduced cardiac rate, and cardiac force, ultimately leading to decreased oxygen demand. Clinically, verapamil and diltiazem are used in the prophylaxis of angina, in the treatment of hypertension, and other disorders. In terms of pharmacokinetics, toxicities, or interactions, these drugs can be given orally or IV. They tend to have a duration of 4 to 8 hours, with some toxicities associated with them, including atrioventricular block, acute heart failure, constipation, and edema. In terms of drug-drug interactions, verapamil-diltiazem effects are additive with other cardiac depressants and hypotensive drugs. Nifedipine, the dihydropyridine, blocks the vascular L-type calcium channels greater than the cardiac channels. Blocks the vascular channels to a higher extent than the cardiac channels. So verapamil-diltiazem non-selective. Here, nifedipine selective for the vascular L-type calcium channels. Adverse effects are like those of verapamil and diltiazem with less cardiac action, and clinically useful in the treatment of angina or hypertension. Pharmacokinetics, this drug is given orally with a duration of 4 to 6 hours, and toxicity could be excessive hypotension. And note that its effects are additive with other vasodilators. Now, the other dihydropyridines are like nifedipine, but slower onset and longer duration, up to 12 hours or longer. Calcium channel blocker overdose. Treatment guidelines of acute cardiovascular adverse reactions. So, symptomatic hypertension requiring treatment. The primary treatment would be dopamine or norepinephrine, and the supportive treatment would be IV fluids. For the adverse reaction of bradycardia or AV block or asystole, drugs such as isoproterenol or norepinephrine are useful. And they will require IV fluids, slow drip. Lastly, rapid ventricular rate due to anterograde conduction in flutter fibrillation with WPW or LGL syndromes. So the primary treatment is direct cardioversion, and supportive treatment is IV fluids. The next drug we'll talk about is ranolazine. And this is a drug that inhibits late sodium current in the heart and may also modify fatty acid oxidation in the body. Its effects are to reduce cardiac oxygen demand. Fatty acid oxidation modification may improve efficiency of cardiac oxygen utilization. Clinically, it's used in the prophylaxis of angina. And in terms of PK, toxicities, and interactions, it's orally administered with a duration of 6 to 8 hours. Toxicity has been observed of QT interval prolongation, as well as nausea, constipation, or dizziness. In terms of drug interactions, inhibitors of CYP3A increase ranolazine concentration and duration of action. So, ranolazine is one of the latest anti-anginal drugs approved by the FDA. It's thought to decrease cardiac demand by acting on cell metabolism. And unlike calcium channel blockers or nitrates, ranolazine's effect is not due to a reduction in heart rate or blood pressure or to vasodilation. It may reduce the excess late sodium influx, thereby destroying calcium overload and increasing left ventricular wall tension. This causes decreased myocardial oxygen requirements, and the patients may experience dizziness, headaches, constipation, and nausea. Ranolazine has the potential to prolong the QT interval and should only be used in patients unresponsive to other antianginals. And it's contraindicated in patients with pre-existing QT prolongation or hepatic impairment. In patients with diabetes, ranolazine has the added benefit of lowering glycosylated hemoglobin levels. Now, certain metabolic modulators are known as fatty acid oxidation inhibitors because they partially inhibit the fatty acid oxidation pathway in myocardium. Because metabolism shifts to oxidation of fatty acids in ischemic myocardium, the oxygen requirement per unit of ATP produced increases. The partial inhibition of the enzyme required for fatty acid oxidation, called LC3-CAT, appears to improve the metabolic status of ischemic tissue. And so, ranolazine is an important drug, inhibits late sodium current in the heart, may modify fatty acid oxidation, but is clinically useful for the prophylaxis of angina. So, where the drugs end are some surgical procedures. Here we have a transluminal coronary angioplasty, where a balloon is inserted into the blood vessel in question, and the plaque is squeezed against the walls on both sides. And after the lumen is widened, the balloon is deflated and the catheter is withdrawn. So they went in for an opening of a blood vessel, but they pulled it right out. That's what this procedure does, so that an opening stays. A percutaneous transluminal coronary angioplasty. Here you have a stent in an artery, lumen of the artery and the stent, and this maintains the patency of the blood vessel.